Hey, how's it going?
Good. How are you?
Good, good.
I don't know if this will work right, but we'll see. Are you the only one on right now?
For now, yeah.
Can I
Tech.
just test to see if I know what the hell I'm doing? Let's see. Can you see my screen now, Debbie?
Yep.
What do you see?
Metastatic tumors of the spine.
Okay, good. All right. I don't know what the hell I just did there, but whatever.
How long have you been here at Northwestern now? It's been
This is 3.5 years now,
3.5. Nice.
something like that. Goes pretty quick.
Fun, right? Give people a few minutes to trickle in.
Wow. So you do a lot of basic science stuff or just coding stuff? Like for the R1 grants, you have to do like pretty basic.
All right. Give it like one more minute. All right. Looks like we have about 9 or so people, so we can get started. I'm sure more will trickle in, but we'll introduce Dr. Walensky today. We're lucky to have Dr. Walensky from the neurosurgery department giving us a lecture on metastases to the spine. He's a professor of neurosurgery and orthopedic surgery, has a dual appointment, vice chair of the program as well. And he did his training at Baylor and fellowship at Johns Hopkins and actually stayed on there as faculty for a long time before being recruited here to Northwestern to kind of head our spinal tumor program. So without further ado, here's Dr. Walensky, and I'll let him tell us about metastases to the spine.
Thanks. So obviously it's a small group of people here today, but I guess that's good because then we can make it sort of informal, and feel free to jump in if you guys have any questions or if I either speak too quickly or too slowly. But just so I know, What years are you guys, gals?
I'm a third year.
What are you going into, Peter? Do you have any idea what you want to do in life?
Spine, hopefully.
Oh, okay. All right. And Beijing and Mary Catherine?
I'm one of the second year residents and definitely interested as well.
And I'm the new PA to the team.
Okay, great. So you're forced to be interested, right?
And interested on my own, yeah.
All right. So that's great. So you know, some of this stuff you've probably already seen when you're on call and everything, but this is just how I think about metastasis, and it's sort of a journey through kind of when I started off as some of this stuff is actually from when I was a resident and then as a fellow and then all the way through my career. And as this metastasis to the spine and has been an old topic, but it's constantly evolving and changing. So you have to kind of keep your finger on the pulse as to how you should treat these things. Assuming I know how to change the slides. Okay, so when you think about metastasis to the spine, there's about 1.5 million new cases of cancer every year. And with that, 725,000 deaths from cancer every year. And the major cause of death with this is really complications related to metastatic disease. The site of metastatic disease, the skeletal system is the third most common site, and after lung and liver. And if you think about the spine, the spinal column is a large portion of your skeleton, and so there's a large proportion of metastasis that come to your spine. 90% of cancer patients will have metastasis on their autopsy studies. It doesn't mean that they're all symptomatic, but 90% will have some. And 30% of patients with spinal metastasis will be symptomatic to some degree. And 20% of cancer patients with spine involvement will develop spinal cord compression. This is, so when I trained at Baylor, so this kind of dates me, but this was looking at the cases that we had at MD Anderson. So even though there's an interesting relationship between neurosurgery and MD Anderson, because neurosurgery happened to be the one place that was staffed by Baylor. The rest of it was University of Texas. But if you look at all the different tumors that were seen at MD Anderson, and these numbers have changed over the years, but really the percentages haven't changed. Lung, breast, prostate, and blood tumors are the most common tumors that are involved with metastasis, okay? And where do these things go? Well, part of this has to do with the blood supply of the spine. Part of it has to do with just a pure numbers thing, but 70% of metastasis will go to the thoracic spine, 10% to the cervical, and 20% to the lumbar. The majority of metastases go to the vertebral body, but you will see them in the posterior elements as well. Now, I try to simplify how I think about spinal metastasis, partially because I'm not a complex person, but I like to think about spinal metastasis and how it affects us in two different categories. One is pain and the other is neurologic. And so when you think about pain, I divide these in three different simple categories: local pain, axial pain, and radicular pain. I'll go through what I mean by these different things. So local pain is constant. It doesn't change when you move from lying down to sitting or going from sitting to standing. And it doesn't get better when you're lying down. There tends not to be vertebral body collapse or spinal deformity. And the thought behind what causes this kind of pain is it's periosteal stretching from tumor, okay? And I'm going to just show you the tumor examples I'm going to give you are just going to all be breast cancer to keep that simple. But here's a person that has significant back pain, but you can see that the vertebral body is all in one piece, but there is tumor involvement in this vertebral body, and this person has significant pain. So these people don't have instability, but they have pain. Now, when you think of axial spinal pain, this is sort of instability pain or mechanical pain. And it's the same like with degenerative spine disease, except for it's a little bit more obvious in certain ways. It's worsened with movement. And so it is not uncommon for, to get a consult from Prentice or something like that for somebody with bad back pain secondary to spinal tumors. And then my resident or fellow would go by and see that patient. They'll call me and say, yeah, this person's got this, this, and that, and there's a tumor here, and I don't know, it looks okay. Probably can treat them with radiation. They're probably not having that much pain. And you ask them if you got them out of bed, and they say no, because they didn't really want to. But if you got that person out of bed, they might have significant pain, and they're just more comfortable when they're lying down. So this is really from spinal instability, where they might have vertebral body collapse or some deformity or change in the posterior elements causing this instability. And here's another example. Again, a breast cancer, and you can see that vertebral body's been completely destroyed by tumor, and it's disc on disc, and it's obviously unstable. You can also have bone retropulsed into the canal. Now, radicular pain, same kind of pain that we have in degenerative spine, right? Usually constant kind of pain, but it can be made worse by movement, and it's because it's radicular pain, it's a radicular distribution, and you can have severe pain, dysesthesia, and it's caused by nerve root compression. And here's an example of that, where you can see this metastasis of the vertebral body, but it also goes into the frame, and it's pushing on the exiting nerve root. And I think this is the L5S1, so the L5 nerve root being pushed on right here. So that's how we categorize pain. So once you've thought about pain and you categorize it, you also have to think about what kind of tumor you're treating, because that makes a big difference as to what your goals of surgery will be, right? So when you think about tumors, first you got to find out, is this really a metastatic tumor, or is it a primary tumor? Because it makes a difference. So if somebody's not had a diagnosis of some sort of tumor before, then you need to figure out, is this a primary tumor or metastatic lesion? And that's pretty obvious as to how you figure that out, but we can go through that as well. And then you have to understand your goals of treatment. So when we're thinking about primary tumors, we're thinking about cure, but with metastatic tumor, really you're thinking about palliation. And the way I think about surgery for metastatic tumor, rarely am I thinking about cure for that. And I'm trying to make sure that whatever I treat them with, I'm trying to make them and their lifestyle better so that they can get on to their other treatments, because I'm not going to cure them with surgery, but we do have a chance for improving things with chemotherapies or other adjuvant therapies. So when we think about our adjuvant therapy options with our primary tumors, we tend to have limited treatment options, but with our metastatic tumors, these are quite significant, and they get more broad every day. And what's the potential morbidity of our surgeries? Well, with primary tumors, because this is what we're aiming at is for cure, taking on significant potential morbidity is worthwhile in the balance of things, because you're trying to get cure or long-term disease-free survival. With metastatic disease, we're trying to minimize what we're doing to somebody so that we can get them onto the next treatment. So you want to have the least number of complications possible with these kind of surgeries. And the type of surgery, compared to where our primary tumors, we're trying to take things out in one piece. Here, we're going to what I commonly think of as the neurosurgical way of approaching tumors, and that's kind of going into tumors and sucking them out, interlesional type of thing. Okay. Again, primary tumors, your goal is going to be cure, long-term survival. Limited adjuvant therapy and en bloc is your surgical technique of choice, usually for these types of tumors. And metastatic tumors, our goal is palliation. There's going to be adjuvant therapies that we can think about, and our surgical technique is generally interlesional. Now, let's go through our history of treatment of these spinal tumors, okay? So these are just papers that have been published over the years. None of them are really fabulous papers, but they just talk about different treatments for spinal cord compression. And when you look at radiation therapy alone, and this is conventional radiation, so all these papers were put out before stereotactic radiosurgery was available. But with conventional radiation, overall, your percent improvement is about 44%. And you obviously have people that worsen with radiation therapy alone. Okay. When you look at surgery for metastatic disease, and this is again 70s, 80s, and some of these papers are coming out in the 90s, but these are really surgeries from the 80s. Surgery at that time was laminectomy alone, meaning laminectomy without any sort of stabilization, plus or minus radiotherapy. Okay. And when you look at these papers, they're, overall, again, percent improved is about 44%, worse is about 13%, but because we're operating, there's also mortality, right? So 7%. So from this experience of radiation versus radiation plus surgery, and surgery being laminectomy, the decision was made that really we're not doing much with surgery. We're making people potentially worse. And so why don't we radiate people all by itself? And so when I was a resident, whenever you saw metastasis, it pretty much was, okay, call radiation oncology, it's their problem. Well, that changed, okay? And really what changed over time was instrumentation changed. So once we started getting hooks and rods, right, we started improving what we could do. So if you take patients that have metastatic tumor and you operate on them, decompress the spinal cord, and you stabilize them, well, now you see actually improvements in pain, improvements in motor scores. You still have deaths, right? That hasn't changed, but now you're doing better than you were with radiation alone. Okay. And these were for posterior approaches, right? And a lot of these were hook rod constructs and later pedicle screw instrumentation constructs. Now, anterior approaches, it's debatable how much better this data is compared to the other. It's probably the same, and maybe these numbers are a little bit skewed, but people found that with anterior resections and reconstructions, they had the same outcomes too as well, improvement in motor and pain with decreased mortality. So then it shifted the paradigm, okay? And this was kind of mid 90s where we started shifting the paradigm towards surgery again, because if you combine surgery with stabilization. Well, like all of our science, most of it's retrospective studies, and those papers are all retrospective studies, or maybe they were prospective collected data sets, but they're really retrospective studies. Roy Patchell, who at the time he's a neurologist, at the time he was at the University of Kentucky, he decided to do a randomized prospective trial for surgical decompression versus radiation for metastatic disease to the spine with spinal cord compression. And so these are actually one of the few prospective trials in spine surgery. We don't have very many of them, but sometimes every once in a while somebody does great work. And it took a long time to get this done, but this is what he decided to do. So everybody would get the diagnosis based on clinical diagnosis and MRI. All patients were going to be treated with high doses of steroids. This dose of steroids, 100 milligrams of Decadron, as a loading dose, and then 24 milligrams every 6 hours. This dose is based on what radiation oncologists would give for radiation therapy for people with spinal cord compression, okay? And he would stratify these by the tumor type, ambulatory status, and spinal stability. And at that time, we didn't have SINs, and I'll get to what SINs is later, but they would determine what would be stable and unstable. And then they would be randomized to either radiation therapy or surgery and radiation therapy. And this is conventional radiation therapy, okay? The institutions that contributed patients, most were University of Kentucky and then other places as well. Now, what's interesting is if you look at this, MD Anderson at the time contributed 14 patients. And if you looked at my first slide, there were huge numbers of patients at MD Anderson. But the reason why it was only 14 patients is that MD Anderson had already made their decision that surgery was much better than radiation alone. And so they had a lot of trouble sending patients to them. So they were sort of cherry picked as to which ones went to them. What did they find out? Well, surgery plus radiation therapy was better than radiation alone for ambulatory status and length of ambulation after treatment. They even found that non-ambulatory patients became ambulatory, whereas you didn't see that in the radiation therapy alone group as much. I mean, 56% versus 19%. Time of continence was longer with surgery. Frankel scales were better. Overall survival probably didn't change that much, right? Because remember, we're doing this for palliation. This isn't for really treatment, although people that are paralyzed do survive less long. So the conclusion was that surgery plus radiation therapy is superior to radiation therapy alone for the treatment of spinal cord compression caused by metastasis. But keep in mind, there's a caveat to that, and that is these were single levels of treatment, right? So now you got to think about that, and you got to think about it in context of what's going on. So not all patients need surgery, not all patients just need radiation, and you need to figure out which patients go into those different categories. So which patients can you treat with radiation therapy alone? Well, radiosensitive tumors, generally we treat with radiation alone, as long as they have no instability present, no bony compression, or some people that have a stable neurologic status or very limited life expectancy, meaning they have so much going on that surgery is going to hurt them. So what does it mean to have a radiation sensitive tumor? Actually, radiation sensitive tend to be also chemosensitive tumors. And this term radiation sensitivity is based on conventional radiation therapy. Okay, so it's not the same for what stereotactic radiosurgery is. But with conventional radiation therapy, tumors like lymphoma, myeloma, small cell lung cancer, these things are very sensitive radiation therapy, so they melt away. In fact, it's pretty rare in my experience, in my practice, for me to operate on myeloma patients in the acute setting. Okay, because those things, if you treat them with radiation therapy, will melt, and they'll melt very quickly overnight, and they'll get improvement. Sensitive tumors, semi-sensitive tumors, will be breast, prostate, and thyroid cancer. And your not so sensitive tumors, or we call these radioresistant tumors, but they're not completely radioresistant, are going to be your colon, renal cell, melanomas, sarcomas, and squamous cell adenomas of the lung. I should probably put now an asterisk in this category because these are not sensitive to conventional, but they are sensitive to stereotactic. So if you give high doses of radiation, you can get these things to respond. Not as easily as the others, but they can respond. So going back to our pain categories, if you have somebody who's got this kind of local pain, cancer pain, periosteal stretchal pain, but has no cord compression, has no spinal instability, this is a perfect candidate for radiation therapy because you're just trying to control their pain. Okay. What are indications for surgery? Well, sometimes you need it for a diagnosis, but usually we're going to get that by a CT guided biopsy or other means. If they have spinal instability, all the radiation in the world is probably not going to make their spine stable, with the one caveat of multiple myeloma, where those patients, even if they can have an unstable spine from fractures, from multiple myeloma, radiation actually will get those patients to become stable over time in the majority of cases, so they can avoid surgery. Patients that have bony compression, I'm not sure that you can actually ever melt away bone with radiation, but maybe if you gave enough, you could do it, but you would obviously hurt somebody. So somebody who's got cord compression from bone in the canal, that's a different story, right? You can give all the radiation in the world, it's not going to get better. And if they have enough epidural cord compression with cord dysfunction, even with good stereotactic radiosurgery, you're not going to be able to deliver enough radiation safely to that cord without hurting that spinal cord. And so these people need to be decompressed. And radioresistant tumors, like we said, some patients that unfortunately recur despite radiation therapy, or neurologic deterioration during radiation therapy, which is kind of one of the worst groups because those people are also destined to have a wound infection, a wound problem. And those people with spinal instability or axial or radicular pain, those people tend to do very well with surgery. So that this is later adopted by the AO, but this was started by the Spinal Oncology Study Group, something called the SIN score. And it's very similar to what we have with the TLIX score for trauma, for understanding what's unstable and what's stable. I think, it's not something that you necessarily need to swear by. And actually, it hasn't really been validated, but it's a great score to help categorize and put things in your mind of understanding what's stable and unstable. And it all makes logical sense when you go through it, right? So the things that are important for understanding whether or not something's stable or unstable is where it's located, right? Is it a junctional region? Is it mobile spine? Is it in a rigid segment in the spine? What's the pain like? Is it a lytic or blastic tumor? Blastic tumors are things like prostate cancer and some breast cancer, where that bone actually gets harder because of the tumor involvement. And lytic tumors are ones obviously that break up the bone. What's the alignment like, right? This goes to instability. Is there vertebral body collapse? And what do the posterior elements look like? So with all that, you get a scoring system, you add them up, and you figure out what the score is, and you can kind of figure out what's stable, unstable. Usually these people that are in the 0 to 6 category are obvious. These people that are in the greater than 12 ones are obvious when you look at their films, at least obvious to surgeons. But there's this category between 7 and 12 that become sort of indeterminate, where you have to use your gestalt or understanding of and experience to understand what to do. I think this system, this SINS thing, is great for people trying to get their hands wet with this stuff and understand what's going on. It's also very useful for radiation oncologists, rehab folks, and oncologists to understand when to send somebody to you because they're either grossly unstable or they don't know if they're unstable. So looking at some examples here, this is a patient with metastatic renal cell carcinoma to L2. And you can see on the x-rays that L2 vertebral body is collapsed, sort of a planum thing, all right? If you look at the AP, you can see that you've lost the pedicles here on this level. On the MRI scan, obviously collapsed disc on disc with huge amount of epidural tumor going back towards the spinal canal. Renal cell, very radio resistant. It's not going to respond to radiation in the first place. If you radiate that, the instability is not going to get any better. Most likely it'll get worse. So this person would benefit from stabilization and decompression and a realignment. So this person underwent 2-stage operation, anterior and then posterior, to resect that tumor and then realign the spine. Looks like a lot, right? A lot for somebody to go through, but these people can benefit quite a bit from this, and it can make a remarkable impact on their lives and improvement in their lives. The other thing I tell people about tumor work is that I have a sort of a mantra, and that is go big or go home. And that is that with tumor work, you don't want to do anything super minimally invasive, super small, because you want something that pulls out all the stops. Because remember, these have the worst healing potential of all, and you're trying to get something to survive in an environment where you're going to give radiation and chemo and other horrible toxic things to people that have bodies that don't grow bone very well, and you want this to survive as long as possible. So you don't want to do a single level above or below. You don't want to just do a gauge without a plate. Put it all in there because it'll hold up better and make them last longer. This is a slide that I like mostly because it gives me some encouragement in life. This is a slide that this is when we saw patients, we would think about what their median survival is, right? And this slide is had for a long time been always true, where when you saw lung cancer, these people lived about 4 months, so pretty dismal. Same with melanoma, right? Even our myelomas and things, you'd say, oh, 2 years, not that's horrible. Reality of now, with a lot of our dedicated immunotherapies, these people are living a lot longer. So melanoma, I would, for 50% of patients, the average lifespan is greater than 2 years. Lung cancer, the same is true as well. Myeloma, I think it's pretty rare for somebody only to live 2 years now. So, things have changed. Sarcoma is still pretty crappy, but it is getting better as well. That's probably getting better from our surgical techniques. So now that you've kind of got all these different ideas about pain and instability and tumor types and radiation therapy treatment options, and you're thinking about surgery, when you're thinking about surgery, you need to be armed with all the different options as far as how to approach a tumor. So you need to understand what you can potentially get to, how you're going to get to it, and what's going to be involved. So, thinking about this, understanding that posterior laminectomy, posterior lateral transpedicular, costotransversectomy, lateral extracavitary, anterior lateral stuff like transthoracic, retroperitoneal, thoracoabdominal approaches. Anterior, I have medial sternotomy on here. This, I would say, I would rarely use now in metastatic tumor, but we used to use it a lot. But nowadays, I think that our posterior approaches and our instrumentation is so good that we can get away from this median sternotomy, which carries a lot of extra morbidity for people that sometimes isn't necessary in metastatic disease, and your transperitoneal approaches as well. You need to just be familiar with all these different approaches, because you don't want to be caught in the middle of the night dealing with somebody and not know how to deal with that tumor. Other things to keep in mind, think about whether or not this thing is going to cause you a lot of trouble with bleeding in the operating room. And so vascular metastatic lesions, you might want to think about embolizing prior to surgery if you have the time to do it, because some of these things can be super bloody. And a very simple way of thinking about this is think about the origin of the tumor. Where did it come from? How vascular is that organ? Right? So kidney cancers, all your blood's filtered through your kidneys, very bloody. Thyroid cancer, if you've ever operated on the thyroid, very bloody. Hepatocellular cancer, liver, very bloody, right? Pheochromocytoma, I don't know, for some reason I saw a lot of these can be very bloody, and they have other problems as well. Melanomas, surprisingly, can be pretty bloody too. Sometimes they're not very bloody. Sarcomas, we try to take these out on block, but if you don't, they can be super bloody. Angioparasitoma, and now the newer term for this is SFT, or fibrous soft tissue tumor, is solitary fibrous tumor, is a super bloody tumor. And I can think of a case that I operated on twice where we lost 50 units of blood each time. And so these tumors can be small, but exceptionally bloody. And so you want to think about that. Myeloma, we don't tend to operate on, but they are bloody if you operate on it. Now, what about other adjuvants you can use? Vertebroplasty and kyphoplasty. So some people will have metastatic lesions that are somewhat unstable, but they're not so unstable that they're falling apart. It might become more unstable if you radiate them, and they have some pain from instability. And those people actually respond very well to vertebroplasty or kyphoplasty. Most of you know what vertebroplasty and kyphoplasty are, but essentially you're putting a needle into the spine and injecting cement, right? And if you inject the cement through that needle under high pressure, that's a vertebroplasty. And if you make a space with a balloon and inject it under low pressure, that's a kyphoplasty. You know, the companies suggest that maybe you can actually change their kyphosis by putting a balloon in there. And I don't think that's really true. The results from it, though, it can be quite astounding for metastatic disease, and they can improve pain immediately and can be actually durable for patients. And so I think it's a great adjuvant for people. There are certain relative contraindications to this. So people with vertebroplanum, or if the posterior wall of the vertebral body has been violated, you got to be very careful with that. And so unless you have a interventional neuroradiologist that's very comfortable with that kind of stuff, I wouldn't recommend doing that unless you're on standby to decompress them and really are excited about that. So you just have to temper with what you know your people are capable of doing. I personally don't do my own vertebroplasties or kyphoplasties, so I have them go to neuroradiology. So you have to just understand what their experience is and what they're able to do. So what about radiation therapy? So we talked about conventional radiation therapy. So conventional radiation therapy is pretty simple. You just stand there. They draw area on your chest or wherever they're giving the radiation and just blast everything in that area. And they're usually giving it 30 gray for 10 fractions, which is essentially every day for 2 weeks because they don't work on the weekends. Stereotactic radiosurgery is a little bit different. So this is stereotactic radiosurgery, and this is the kind of machine that we have here at Northwestern. There's lots of different machines for this, but essentially what you're trying to do is give a high dose of radiation to a tumor. And what they're doing on these plans is they're outlining where the spinal cord is here in blue, the thecal sac, or what they think the thecal sac is here in yellow. And this is done by either MRI scan or myelogram. And then they're outlining the tumor in red and the epidural tumor they put here in pink, just to understand that. And because the tumor that abuts the spinal cord, they're going to have to underdose that. And so how stereotactic radiosurgery works in a very simplistic way is I kind of think of George Bush's 1,000 points of light, right? Think of like a flashlight. And if you're using conventional radiation therapy, you're aiming that flashlight at your body, and all that light hits your body and travels through everything. With stereotactic radiosurgery, you're using lots of lights, lots of different radiation beams that travel around the body, but they all converge in a single point, and that single point gets really hot or very bright. And so, yes, there's radiation going through your body, but it's low dose going through your body, but at that one point it gets hot and gives a lot of radiation. And so if you can give a lot of radiation in that area, and we're talking about like 24 gray in a single fraction, or some people will dose that a little bit lower, but or up to 30 gray in 3 fractions, then you can give a lot of dose to that area and control tumors fairly well. But there is still failures with that. So just in a nutshell, concluding all this stuff, and you guys feel free to ask questions. Think about when you're seeing these patients, the pain, whether or not it's local, axial, or radicular. Think about what different options you have from a treatment perspective based on actually what kind of tumor you have, radiation therapy, surgical resection, vertebroplasty, all different things you want to think about. Also, whether or not there's instability there and whether or not you need some stabilization for this patient, even if they are going to go under radiation, stabilization is part of that. And if you're going to undertake these things, you just have to be prepared to understand what you're thinking about and understand how to approach these different areas. So with that, why don't I conclude there, and if you guys are still awake or not zombies, feel free to ask any questions.
Dr. Walensky, thanks for that talk. I kind of just wanted to, since I haven't taken call with you, pick your brain about like the standard call case. Mm-hmm. So we had a number of consults from Prentice, The exceptions are the ones where you have an evolving neurologic sign, you've got epidural component of tumor, you've got cord compression. So you obviously you're pushed into the surgical route. That's not too much of a question. But what about the folks? They've got a radiosensitive tumor. They've got it at a couple levels. It's mild instability, mild concern for instability based off of your advanced imaging, and they're in pain. Now, the question is, so my thought process as up till this point is, how functional are they? If they are somewhat functional enough, give them a chance with radiation, see how they do. If they deteriorate, then think about stabilization. Is that similar to what you think? Is that, would you say that that's wrong, that there's a better way to approach these patients? And again, this is like more it's a tumor that is radiosensitive, but they've got it at a couple levels. They do have pain. It's somewhat functionally limiting. They've got some vertebral body collapse. In that gray zone on the SIN score, they fall somewhere under 12. But
Yeah.
What's
So
your approach?
it depends the tumor. So if it's myeloma, is a great one. Myeloma, even if they are unstable by your SIN score, and you radiate them, and it's not high dose radiation, what will happen is their pain will get better, and actually they will rebuild bone and become stable. So even people with, that I've seen with craniocervical instability, thoracic instability, lumbar instability, it's amazing how they'll reform bone. Some of those patients won't, okay, but I would give them the benefit of the doubt with radiation. And those that don't, after they've gone through all their treatment and they're in remission, then you can offer them a stabilization procedure. But it's super unlikely that one of those patients is going to get worse with radiation. Okay. Unless they have, bony compromise in the canal, it's a different story. Sometimes you're just stuck, right? And it's disappointing because they have to recover before they can get onto their chemotherapy and other treatments. And so that's what you're balancing. The other radiosensitive tumors, I think if they're, mildly unstable, I think you can get away with it. Because those tumors are going to melt away. So there was a case actually 2 days ago that I think Jeff Strisik was on call, but this was a guy who was diagnosed with a tumor called myeloid sarcoma, and he had bad cord compression, weak in his legs, 2 out of 5 or something like that, and massive tumor there with big paraspinal component to it. And the tumor name myeloid sarcoma sounds like a sarcoma, but it's not a sarcoma. It's you might have heard the term chloroma, but this is a leukemia. It turns into a solid type of tumor. Those are radiation sensitive tumors, and just with low dose radiation overnight, that stuff melted away and neurologically is better. So you could have turned something like that into some, I got to operate on that, and then you're taking something that turns from a laminectomy into multi-level fusion, and then you go crazy and do all this stuff, and then you get your final pathology and you're super disappointed, right? Because you've now taken this patient and they have to recover from that, and they're going to be recovering for about 4 weeks before they get their real treatment, and during that time they actually might get worse, right, from their tumor. Then there are these people that, like you said, the ones that are bad spinal cord compression, wildly unstable, they're obvious, right? To a certain degree. Just have to be healthy enough to make it through surgery.
Right.
But you have these other people that are in that kind of gray zone, and you have to balance it, because sometimes they're in that gray zone of they have a little bit of epidural involvement. That's not bad, but it depends the tumor type. So if they have epidural involvement with impingement on the cord, maybe they're not myelopathic yet. You have to decide, can I get enough stereotactic radiosurgery into that tumor, to actually affect that tumor? Or will I be underdosing that tumor? And if I'm underdosing that tumor, then I'm sort of wasting that patient's time, right? In those cases, then you might do what Mark Bilski and the guys at Sloan Kettering have popularized, the separation surgery concept, where you instrument them, but then you just resect the epidural component, and then you give them stereotactic radiosurgery while they're recovering. So within that 2-week zone, because the stereotactic radiosurgery doesn't seem to affect our wounds as much. You have to be careful of how you plan it, but you can get those beams to not go through the wound incision area so that it heals better. And that's a way to get around that stuff too. The other thing that I also try to keep in mind with metastatic disease is I think of surgery and radiation therapy is very similar things. They're tools for palliation, but they're not for cure. Your chemotherapy is the cure thing, if it's going to work. So I even with radiation therapy, if you see a lesion in the spine, doesn't even mean it has to be radiated. Chemotherapy might work on it. You just have to also get the radiation oncologist to pull back a bit too, because every time you radiate something, you probably make it less likely to be able to get chemotherapy to penetrate to that area, because there will be fibrosis and scar. The other thing, though, you guys know because you're orthopedic surgeons, is our bone makes our bone marrow. And you radiate enough of these people, enough of their spine, you've lost a lot of bone marrow. And I think you can get into some bone marrow suppression by radiation treatments.
I guess I'm trying to develop my gut in terms of, you know, these people aren't the healthiest. They rarely show up. It's like rarely a young healthy person is otherwise fine other than this tumor. At least from what we've been getting practice, it's a 70, late 70s, early 80-year-old person, and it's almost always prostate mets, breast mets, and I think we've treated people well, and they've seemed to the folks that have like followed out a couple months seem to be doing okay. But it's always a question of, you know, like we could take this person back, stabilize these two thoracic levels, like going 2 screws up, 2 screws down, bridge them, and see if that gives them enough stability to get around as they progress to other more curative or definitive treatments for their cancer. How do you weigh the, Dick, do you view the oncologic component of their medical history to be a large, like a big issue in terms of their perioperative optimization? Or do you kind of say they have this tumor, we're going to deal with it, see if they're healthy enough otherwise, and just take them back?
I think it's a balance, because you really understand what they're going to get from a chemotherapeutic perspective and what kind of options they still have, or what they haven't gone through. And I think that, you know, these patients, some of them can be super rewarding because you've taken somebody who's been immobile because of pain or neurologically compromised and you've made them better. But at the same time, they can also be very mentally disappointing experiences to you, because you do all this work and they just don't do well, right? And sometimes you can't predict which ones those are going to be, but usually you can. If you have enough experience with them, you get a gestalt. So I think the SIN score, it's sort of nice because it categorizes people. There's these other scores like the Takahashi score that takes other things into account, but I think nothing plays a bigger role in it than your general gestalt about how somebody's going to do. And you have to, sometimes the better part of valor is walking away, right? Where you think, oh, I'm doing something, I'm not optimizing this patient by walking away and doing their best for them, but sometimes not much you can do. And especially if their spine is riddled with mets, you can sometimes really be disappointed when you get into. Because that patchal stuff is a single metastasis study, solitary metastasis. So it's, you know, they've taken the best of the best, right? That's not what you see every night on call.
One last question. I don't mean to hog all the time, but what about the fact that no one's ever willing to comment on expectancy? So no oncology note will ever have a definitive expectancy. From what you were telling me,
they always say 6 months, right? Because they know that our threshold is 3 months. So they're always going to say 6 months. So I think it's partially you're going to have to make that decision in your mind. Do you think this person's really going to be there for longer? And a lot of these people now, it's pretty hard for them not to make it 3 months because the chemotherapies are so good.
Yeah, JP, along those lines, I totally agree with that slide that you have and sort of the perspective that over the last decade, our therapies have really made a huge difference in the life expectancies of many patients with metastases. But if you ask oncologists, like I have some good friends and I've been in an argument with them before, and they claim that with the data that they have, that the only cancers that have been improved with chemotherapy are breast cancers with the receptor, specific treatments like tamoxifen, and everything else, it's been the same. So I guess my question to you is, how do we reconcile that? Is it possible that we're only seeing patients and we're only studying patients with bony metastases, and perhaps that's like a subgroup of individuals in which their life expectancies have changed?
Well, I mean, you know, there are these subgroups. So like if you look at melanoma, for example, 50% of them will respond to treatments, 50% won't, right? And those that respond, their response usually lasts at least 2 or 3 years or so, but then they get overwhelming metastasis. So they're better, but they still die, right? So it depends, I guess, what your needle looks like. But and also lung cancers are much better than they used to be as well. I mean, I'm sort of surprised that your oncology friends say that, but it might be what they're treating. I mean, I think sarcomas and things haven't changed that much. To me, that's still super dismal. And the chemotherapies haven't gotten any better for those. It's the same stuff that we've always been giving them. It just makes them sick, and then they explode with tumor. The multiple myeloma is super better than it was. I mean, now with the stem cell transplants and everything that they're doing, I see these people now in my clinic that Dr. Meta sends to me that are like 10 years out, and their spines look horrific, and I kind of wonder what the hell I'm supposed to do with these people. But
Yeah,
you know,
right.
so that's what I think is happening now. Is the next evolution of this is figuring out what to do with these chronic messes, right? Because I think the complexity of what you're seeing is way worse than we saw 10 years ago, where then you'd see these people that were fairly straightforward. And in my practice, I always thought the metastatic people were great people to see because they were a slam dunk and you knew they were going to get better from your operation. Now I think people are further along in their therapies that maybe they're not as obvious slam dunks. If that makes sense.
Just a couple of quick questions, JP. Thanks for the presentation. These are pretty simple questions, but something I never really found the answer to. What about the teaching about, like how you split up local pain, axial pain, and radicular pain? Local pain that increases with recumbency. Like I never really found an explanation for that, but I was taught, tumor pain kind of is related to that. I don't know if it's related to like venous distension when you lay down, or is that anything
Hard to
you've heard?
say. I mean, I don't know. So one of the things I have been sort of looking at in a very simplistic way is with my primary tumors, right, where I do spondylectomies, just looking at the specimens that they come out, because these people have pain. But when I look at their preoperative imaging, their CTs and MRI scans, I don't think that they're unstable. They're, of course, unstable after I'm finished with them, but they're not unstable by our definition beforehand, right? And so they probably fit into that category of periosteal stretching or whatever. But when I have that vertebral segment in my hand, right, with a disc above and below, and I squeeze it, it flexes. Like there's clear movement there. So they are unstable probably in that Punjabi definition, just not unstable enough that you would pick it up on our imaging. And maybe
Yeah.
that's what some of these people are, right? I'm sure that if you fused a lot of these people that don't look that horrible, they might feel better with pain, but it might be too, I mean, that might be kind of super aggressive, I guess, right?
Right. Everything that makes sense. And then something a little bit less or more rare for us to see as orthopedic surgeons is intradural Mets. Kind of touch base with you about a couple patients with concern for that. A, what's the mechanism of spread? Is it still hematogenous or is it intrathecal? And B, like how often do you see that?
So if they have brain mets, then it's probably CSF spread, right? Leptomeningeal disease, that kind of thing, which by definition, if they have intradural extension or spread, it is leptomeningeal disease. It's super rare to see that, mostly because those people are super sick by the time they get that. And so their general life expectancy is about 6 weeks when you see that. So you want to really control yourself from operating on those people, because it might be a satisfying operation at the time and kind of fun, but it's super disappointing. Intramedullary Mets is really disappointing because they don't have a chance to recover the neurologic dysfunction that you might give them from the surgery.
Gotcha. Makes sense.
But it is pretty, so I have seen, since I've been here, I don't know why I've seen more here than I did before. Maybe it's just that the oncologists are more apt to refer these people, but I have seen a number of people that were going to undergo their treatment for multiple myeloma that were found on their screening imaging to have intradural lesions, right? That look like schwannomas or neurofibromas, something like that. And I actually remember one week where I got both of them coming to my clinic a couple hours apart from each other. And one of them I watched and one of them I operated on. Both of them were asymptomatic, but the one I operated on already was fairly large. And neither one of these people had seen their treatment yet for the multiple myeloma. But once they get their treatment, it's pretty much a year, right, for their treatment for their multiple myeloma and the stem cell transplant. So if that thing grows during that time period, you're stuck, right? And so the big one I operated on, the little one I just watched before, so as a prophylactic thing for their treatment, but it's otherwise a pretty rare thing to do.
Gotcha.
Hey, Dr. Walensky, do you think there's a role for percutaneous instrumentation in any of the patients that just have isolated axial pain without any neurologic compromise?
Yeah, I think so. I mean, I haven't done that very much. I've done a couple cases like that just because I haven't seen that much of that. But I think there's definitely a role for it. I mean, it's like the internal brace, right? You know, when we first started doing this stuff, we actually only grafted these people, and I'm not talking about the percutaneous stuff, but the open stuff. We only grafted these people because that's the only way you can get paid, right, for instrumentation. So if you do instrumentation without grafting, you don't get paid. And so you would graft these people, not expecting them to fuse. I think luckily we did graft these people because many, if they survive a long time, then they will fuse, surprisingly, even with all these horrible things we do to them. But I think percutaneous screws is a reasonable option. Somebody's got a limited life expectancy. But if you don't graft these people, they will develop pseudoarthroses, right? And so you're going to have to deal with that hardware problem later down the road. And if you think about like the perc screws that you see in degen spine, those screws are usually supplementing some sort of anterior construct. And that anterior construct has BMP in it or some sort of thing to try to encourage fusion. But we don't use BMP in tumor. So you have to think of how you're going to get that thing to fuse if you expect them to live long enough. That's the only downside of that, but I think it's a great option.
All right. Well, thank you for taking the time to present to us. It was a excellent talk.
All right. Well, you guys have a great evening. If you don't have any other questions.
Yeah. And if we do that, we've recorded this lecture too. So if any of your residents want to get access to it as well, I'm sure we can send the link.
All right. Sounds great.
All right.
Thanks a lot,
very much.
JP.
Thanks, Dr.
Talk to you guys later. Have a good evening.
Bye.
Bye-bye.